Hello, my name is Teresa Gachinos, and today I'll be introducing you to social cognitive theory and motivational interviewing. Social cognitive theory. Social cognitive theory is the theory that learning occurs in a social context with dynamic and reciprocal interaction of the person, environment, and behavior. Social cognitive theory emphasizes social influence and that there is both internal and external reinforcements to our actions. Social cognitive theory considers the unique way in which individuals acquire and maintain behavior while also considering the social environment in which individuals perform that behavior. There are 6 pillars that are essential to social cognitive theory. They are reciprocal determinism, behavioral capacity, observational learning, reinforcements, expectations, and self-efficacy. Reciprocal determinism is the most central concept of social cognitive theory. This portion refers to the reciprocal interaction of a person, their environment, and their behavior. So it's how an individual with a learned set of responses in an external social context responds to stimuli to achieve their goals. Behavioral capability refers to a person's ability to perform a behavior through their knowledge and their skills. In order for someone to be able to perform a behavior successfully, they must know what they need to do and they must know how they need to do it. People learn from the consequences of their behavior, which also affects in the environment and how they live. Observational learning asserts that people can witness and observe a behavior that is performed by another one and then reproduce that behavior. This is often shown by modeling a behavior. If someone sees a successful demonstration or a successful performance of a behavior, then they themselves can complete that behavior successfully. Reinforcements refers to the internal and external responses that someone gets from a behavior. This can affect the likelihood of continuing or discontinuing that behavior. Reinforcements can be done by someone else, or they can be in the environment. They can be positive or they can be negative. This is a construct of social cognitive theory that ties into reciprocal relationship and that reciprocal determinism between someone's behavior and their environment. Expectations are the anticipated consequences of someone's behavior. Expectations can be health-related or they cannot be health-related. People anticipate the consequences of their actions before they begin or engage in a behavior. These anticipated consequences can influence whether or not the behavior or skill or task is successfully completed. These expectations largely derive from previous experience. And finally, self-efficacy. Self-efficacy is the level of someone's confidence in their ability to perform a behavior, skill, or task. This self-efficacy is influenced by someone's specific capabilities as well as their environmental factors to perform a behavior. Motivational interviewing. Motivational interviewing is a practice that can be used concurrent to other therapy methods and styles. Motivational interviewing for the medical professional while taking time to learn and cultivate is beneficial as it outperforms traditional advice giving 80% of the time. Motivational interviewing works based on the goal of increasing a patient's motivation to change. This, however, is not done by teaching new skills or providing them with new advice. This is done by encouraging change talk, helping the patient identify their own personal reasons to change, and motivating them to make that change. It is important to note that motivational interviewing does not require the identification of a patient's stage of change to be successful. Motivational interviewing revolves around 4 pillars of practice or the spirit of motivational interviewing. These 4 pillars must be present in a motivational interview in order to have a successful session. These 4 fundamental elements are partnership, acceptance, compassion, and evocation. The building of the relationship between the medical professional and the patient is known as partnership, as the ideal relationship between these 2 parties should resemble a partnership. This pillar not only builds the relationship between the 2 parties, but it also allows for the patient to be more trusting and more willing to open up to their medical professional. Statements such as, "We are going to work on this together to help build the partnership." It is important that medical professionals avoid arguing with the patient to try to encourage change and accept what the patient has to say. Acceptance is an important key to motivational interviewing. Without acceptance, the partnership between the medical professional and the patient cannot develop. The acceptance portion of motivational interviewing realizes that someone's best motivation to change comes from within themselves, and that the patient is responsible for selecting their change, moving forward with the goal, and accomplishing their change. A medical professional, however, it is equally important in accepting their client and their client's change-talking goals. It has been found that a medical professional's belief in the client's ability to change greatly impacts the client's outcome. Compassion is the portion of the motivational interview that implies both the use of empathy and acceptance while practicing listening. This portion encourages the medical professional to listen to what the patient has to say and to capture the words and phrases they are using to express empathy. For example, let's say you're counseling a patient who needs to lose some weight to benefit their health. The patient may express their ambivalence towards making this change. Utilizing statements like "losing weight feels beyond you at this moment" not only expresses empathy, but leaves the patient opportunity to elaborate and to continue on this thought while responding to resistance. Empathy is vicariously experiencing the feelings, thoughts, and experience of another, while sympathy is when whatever affects one person similarly affects the other. The difference between empathy and sympathy is important. When people empathize with someone, we are projecting ourselves into their situation, imagining how we feel in their situation. When people sympathize with someone, they experience the same level of emotion and then feel exactly how the other person feels in a situation. When a medical professional uses empathy, they express an understanding of the patient's experiences, pains, and concerns. This empathy can be used to express an understanding of those feelings and can be used to communicate that the medical professional has an intention to help. In the medical professional-patient relationship, empathy has been found to be beneficial to patient care, increasing positive outcomes. On the other hand, sympathy in the medical professional-patient relationship does not always see the same positive outcomes. Sympathy has actually been associated with emotional strain on the medical professional as it skews their objectivity. Empathy not only plays an important role in outcomes, but it also plays an important role in the relationship. At its core, this working relationship must have empathy. Finally, it is important to evoke motivation in the patient. This level of motivation can be measured by the amount of change talk that a patient is using. In patients, change talk can be identified when statements are made that shows future action to achieve their goal. For example, if you're working with the same patient who needs to lose weight, change talk statements would be, "I want to lose weight," or "maybe I'll start walking during my lunch hour at work." There are several limitations of social cognitive theory. Some of these are that it assumes that the changes in environment will automatically lead to changes in the person. Social cognitive theory heavily focuses on the processes of learning and disregards biological and hormonal predispositions that may influence behaviors. And social cognitive theory does not focus on emotion or motivation. There is minimal attention to these factors. This is where motivational interviewing picks up the slack, as it uses self-motivation to change people while not teaching them any new skills and focusing on self-efficacy and building motivation. Westra et al. Examined the use of motivational interviewing as a pre-treatment. 55 participants with at least one anxiety disorder were enrolled. 30 participants were given no pre-treatment, while 25 others received 3 weekly 1-hour motivational interviewing sessions. After pre-treatment, all participants were enrolled in group therapy sessions. At baseline, pre-treatment, and post-treatment, participants assessed their anxiety symptoms using the Anxiety Sensitivity Index, the Fear of Negative Evaluation Scale, the Penn State Worry Questionnaire, and the Back Depression Inventory 2. Researchers found that not only was pre-treatment successful in motivating change in patients, but that patients who received motivational interviewing saw greater decreases in anxiety, which were maintained at 6 months. Barclaw et al. Researched the effects of combining therapies in a randomized controlled single-blinded clinical trial. 36 participants were subjected to a 9-month in-home therapy sessions. There were 17 participants in the group that integrated therapies and 15 in a routine care group at the end of a 9-month period. There were 4 dropouts from the program as there were 3 deaths and 1 person refused to participate during the study. Participants were given, based on case specifics, up to 29 therapy sessions with the median number of therapy sessions at 22. To examine patient outcomes, the Global Functioning Assessment Scale was used to determine the level of global functioning. The Social Functioning Scale was used to determine the level of social functioning, and the Positive and Negative Syndrome Scale were used to determine symptoms. At the end of the 9-month period, there were no significant differences in the symptoms of patients. However, the integrated group saw significantly higher positive symptoms and lower negative symptoms, along with higher global functioning scores. As these two studies show, the result of combining these two styles leads to a more positive, long-lasting patient outcomes with pretreatment, and while co-treatment leads to less relapses and greater improvement in patient functioning.